Good evening and welcome to tonight's Trying Without Success, Understand Your Next Steps webinar. In the spirit of reconciliation, Monash IVF acknowledges the traditional custodians of the country throughout Australia and their connections to the land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples joining us today. My name is Amara Phillips and I will be your host for this evening. I am the audit coordinator for the Queensland's donor sperm program for Monash IVF's donor and surrogacy team. I recently joined Monash IVF team in August this year, having completed my Bachelor of Biomedical Science through the University of Southern Queensland in Toowoomba. I love learning and I love people, and I'm so excited to see how working in the fertility industry will expand on my interests. We are committed to empowering the next generation of parents on their journey to parenthood. We are here for people at all stages of their fertility journey, proud to support patients of all genders and sexualities on their pathway to parenthood. The entire Monash IVF team are incredibly passionate about the care and support we provide our patients. Monash IVF provide world-leading scientific and medical services. We have clinics across Australia in Victoria, New South Wales and Queensland, and sister clinics in the Northern Territory, South Australia and Western Australia. Here are the services we offer. We provide comprehensive reproductive care. We offer everything from fertility testing through to IVF, IUI and ICSI, and of course we can support a variety of donor treatment options. The Royal Australian and New Zealand College of Obstetricians and Gynecologists recommends that all individuals planning a pregnancy consider genetic carrier screening to assess your reproductive options. About 1 in 30 reproductive couples who have genetic carrier screening will find out they have an increased chance of having a child with a single gene condition. As of November 1st, Medicare introduced a rebate for 3-gene panel genetic carrier screening for the 3 most common conditions: cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. The introduction for this 3-gene panel rebate is an important and progressive reproductive health measure. However, Monash IVF Group continue to urge patients to do the expanded genetic carrier screening panel. The expanded panel tests for over 400 genetic conditions, including the 3 previously stated, offering significant additional information about serious conditions that could be passed on to children. The expanded panel test is $695 out of pocket for one individual or $990 out of pocket for a couple. Monash IVF has financing options available. Here is a quick look at the agenda for tonight's webinar. Our specialists will be sticking around at the end of the presentations to answer your questions. Please submit your questions for the Q&A using the Q&A button at the bottom of your screen. We will do our best to answer your questions, but we might not get to them all. It's important to us that you get the information you need. So if your question isn't answered, we do offer complimentary phone chats with my team of experienced fertility nurses. The nurse inquiry team can provide you with the advice about what your next steps could be and can answer any questions you may have about fertility or fertility treatment. You can scan this QR code to book a complimentary nurse chat. My team can also help you book an appointment with one of the doctors if you wish. Whilst we do our best to be affirming, we just wanted to flag that this webinar may include gendered language or medical terms. We know that not everyone identifies with these terms and that people may use different terms to describe themselves or their bodies. We're proud to support patients of all genders and sexualities. Everyone is welcomed in our clinics. Athletes, please be aware some fertility medications will require an approved exemption. Please consult with your medical professional before starting these medications. The information provided in this webinar is general in nature and does not replace personalized advice from medical professionals. Our first presenter this evening will be Dr. Varoshna Kaul of Victoria. Dr. Kaul is an obstetrician and gynecologist providing care to patients across Victoria. Dr. Varoshna offers personalised care in achieving pregnancy through to delivery and has a keen interest in research and teaching. In our first session, Dr. Kaul will take you on a deep dive of factors impacting fertility. She will explain factors that influence the egg provider, sperm provider, and person carrying the pregnancy. Our second presenter will be Dr. Namrata Bajra of Queensland. Dr. Bajra is an obstetrician, gynecologist, and fertility specialist who was trained in tertiary hospitals of Queensland, Victoria, and Tasmania. Dr. Bajra is committed to providing a supportive and calm environment for her patients to experience the best possible care at all times. In our second session, Dr. Bajra will be discussing investigations and early intervention options. She will provide you with clarity on the different initial investigations and when to seek help. Our final presenter will be Dr. Nikhil Patravali of New South Wales. Dr. Patravali is a highly experienced gynecologist and fertility specialist working with Monash IVF in Western Sydney. Dr. Patravali's caring nature resonates well with patients as he focuses on creating a supportive environment, has a compassionate nature, and kind and caring approach, which is well received by all of his patients. In our third session, Dr. Patravali will discuss treatment options, including the IVF process and next steps.
Good evening. My name is Varoshna and I work in Victoria, and I have the privilege of watching women go through fertility if they need it, but I also look after their pregnancies and deliver babies. So I go through them through the whole journey, which is, like I said, a privilege and immensely satisfying. Today, I'm going to discuss the factors which are impacting fertility, and we'll discuss about what are the different factors and how can we improve them. Next slide. So we all know that, and it has been sort of discussed and mentioned immensely about age. And a lot of times it's a negative as well, because women are told very early that age is a factor. And, you know, at 30 and 35 nowadays, girls come up to me and say, oh, are we too old? Should we be freezing our eggs? What is the truth behind it? Yes, age is a factor. We know that genetically we are programmed to have a best fertility in the below 35 years of age, and about 35, the fertility declines. In fact, the fertility rate in a cycle is as high as 30 to 35% till that point, and then the decline till 40 sort of gradually happens, and there's only a 15% chance of pregnancy in a cycle at the age of 40. And this is attributed to a lot of things. One, the aging of the eggs. Second, the way that they sort of enter into the reproductive cycle, as well as chromosomal sort of diversification and forming of gametes, which means that there may be more chromosomal errors. And that's why aging is an essential factor. However, having said that, we have to be mindful of the fact that the age is always reflecting the age of the eggs, and it doesn't actually generally specify that a woman is old, which I try and underline quite a few times, that age is to be considered as a factor, but there are so many other factors which can affect your fertility. This includes lifestyle, and as we know, living in this advanced age where there's a lot of influences from outside. So the lifestyle factors, which include stress, which includes what we eat, and the multivitamins, the antioxidants, all of those can have influence on the fertility of a person. Genetics is something that we can't really modify in the terms that we are born with what we are born, but it does have an impact, and I'll be discussing that in the slides as we go forwards. In addition to that, we have to talk about diseases as well. And these diseases are diseases like endometriosis, polycystic ovarian syndrome. All of these can impact fertility. And if you're aware prior to the sort of starting the journey of fertility, that yes, there are a few issues, then maybe it's wiser, as we say, to just try for a 6 months period instead of giving those 12 months, even at a younger age, before seeking advice from a fertility expert. All these factors will affect eggs. They will affect, I've been sort of focusing more on the eggs, but also age will also affect sperm. And it will also affect the person who's actually carrying the pregnancy. Next slide. What are the indicators? So what could make you see the red flag, and where would you start thinking about, should I be concerned? And an exposure to a sexually transmitted infection can be something that has to be kept in mind. The reason for this is that sexually transmitted infections, which are quite common in the early early youth, you could say, currently, we see that even syphilis is coming back, gonorrhea is coming back, and this could be related to being a bit young and not so careful about using condoms and stuff. But however, having said, most of the sexually transmitted infections can be treated, and if they are picked up early, it is actually quite it would have minimal impact on fertility. But being aware and being able to pick it up before these infections can, let's say in a woman, if there is an infection like chlamydia, which basically has no symptoms sometimes, it can, of course, cause a woman to become very sick and, have a very hectic course, let's say, admission in the hospital, cysts and infection and pus, but most likely it's a very silent infection, which does not create much of an issue in terms of health. And it is also silent for destroying the tubes, which are the site of pregnancy. And therefore, what it does is it damages the little hair which is on the tubes, which makes the egg move towards the sperm. And therefore, that tube is then not able to help support the pregnancy. So having an early knowledge about infections and treating them on time is much more important than actually the sort of stigma that is associated with the infections. And we should not actually sort of delay the seeking of treatment because, like I said, early intervention is going to be effective, and they're not going to have any impact if we treat them quite early. In case of men with undescended testes, early diagnosis is so important. As we know, the testes are lying outside the body, and that's because the temperature required for generating the sperm is 1 degree less than the rest of the body. And if by any chance the testes is undescended or there is trauma to the testes, what happens is that all of these factors can create damage to the sperm. And if picked early, all of these, like a torsion of the testes, can be reversed immediately without any damage to the sperm. However, if it is untreated and the trauma is not resolved and there's pressure on the testes, all of these can cause permanent damage. So again, early intervention, seeking help, and talking out, taking out the stigma of the whole situation. In women and young girls, polycystic ovarian syndrome, which is as high as 22% in the Australian population, and endometriosis, again, so common. 1 in 8 women has some signs of endometriosis. Traditionally, we've been told that periods are painful, periods are heavy, and they should be just managed. But now, as we are knowing more about the whole and knowing that endometriosis and polycystic ovarian syndrome can set in quite early, being aware that irregular periods, having acne and hair growth associated with a weight gain, this is the symptoms that polycystic ovarian syndrome would be associated with. And in endometriosis, the periods are usually quite heavy, and there would be associated painful periods. And this worsens over time. Getting checked up, and we know that, again, the diagnosis for endometriosis may need a laparoscopy. It's not always evident because sometimes it might be severe endo with no symptoms, and on the other hand, there might be minimal endo, but the symptoms might be worse. So we do need to diagnose or think about the diagnosis, because again, why are we worried? The quality of egg in both these conditions can be compromised, and pregnancy may be affected because of multitude of factors. It might be in endo that not only is the quality of egg affected, but the egg count decreases because of the attack on the eggs from the associated collection of blood and endometriomas. At the same time, it might be because of the inflammation in the body, which sort of attacks the egg and the sperm or the fertilized ovum, and therefore decreases pregnancy. So the possibilities of affecting fertility are high, but at the same time, that does not mean that every person who has endometriosis or polycystic ovarian syndrome is going to need an intervention. Having that at the back of your mind, being aware of the situation is much more important, and trying for pregnancy for a short time with these possibilities, with these possible medical issues, and then if it doesn't happen, seeking help is what I would like to stress on. It's always said that if there's a previous pregnancy and it's gone well, we expect that pregnancies will repeat themselves. So if there's a normal pregnancy, it would happen again, and the conception should be fairly easy. And if there is like miscarriages, and especially if there are recurrent miscarriages, more than 2, we start investigating what is the cause for these losses, and whether there's anything that we can manipulate, or whether it is a genetic cause which is causing the miscarriages, and therefore we would like to offer something like testing so that we can actually use the genetically appropriate embryo and help achieve that pregnancy. I've already talked about the menstrual cycle and how it's important that we don't ignore heavy periods or painful periods, and don't just say that that is what is expected and after you have a baby it's going to get better. No, it's probably something more sinister if it is also affecting the conception process. Having a thorough awareness about genetics in the family, and whether there was anything that was sort of mentioned would pass on, if there were issues that were sort of mentioned in the family, like endometriosis can run in families, polycystic ovarian syndrome can run in the families. Sometimes there are the use of gender affirming hormones, and again, we have to be aware of those conditions. Next, please. This is usually my favorite point of discussion, which I usually start with saying that sometimes you feel that maybe God was a man, because if you actually look at a woman's sort of reproductive history, we're born with a very finite number of eggs. We are born with a fixed number, and there's a lot of them, 20 million, but by the time the woman enters her first cycle, which is at the age of nowadays 8, 9, she's already lost a lot of them. So there's only a finite number which enter into cycles, and every month, whether or not we're using that egg for ovulation, there's 1,000 eggs which are lost in that cycle. That's because they're genetically programmed. So the optimal fertility for women would be in the age group of, let's say, between 20, which most of us know. No one is interested mostly in pregnancy at 20. And up to 30, 35, that is where we would assume that after 30, 32, there's a plateauing of the fertility rates. And after that, there's a rapid decline towards 40. And after 40 to 45, we know that not only are there chromosomal issues, but there's a significant decline in the pregnancy rates. So again, being aware that we are on a ticking clock, not a very good term, but yes. And luckily, we have the option of freezing eggs now. So even though there's a ticking clock, we have got an insurance against it. And making use of that fertile window and to get the eggs at the right age, freezing them at the age that the fertility is maximum, I think that's the best thing that could happen to us. Next slide, please. Now, when we talk about age, and I've mentioned this before, the reason is because as the age progresses, there is a lot of complicated steps that the egg is supposed to undergo within the body. And this is going to sort of make it in such a way that it halves its chromosomes and separates in such a way. And it is so complicated. There's a million things that have to happen between the creation from an egg of the gamete, which is going to be able to fertilize. And that's where most of the issues happen with age, with oxidative stress, with stress in general, with diseases. The egg is not able to do that in the programmed fashion, and therefore chromosomal errors increase. And obviously, if there are chromosomal errors, the pregnancy will not happen. It is therefore important that we do make use of that fertility, maximum fertility window. Next, please. The age has, to a certain degree, an impact on the sperm as well, because the quality decreases, again, the same chromosomal issues. And we've also seen that the risk of miscarriage is higher if the man who's providing the sperm is about 45. Next slide, please. Again, a very debatable sort of a topic about weight and fertility. I have so many patients who sort of say that, oh, but that person has a BMI of 40 and never had any issues. Why is it that my weight is an issue? And my answer is that, yes, we know that as the weight increases, not only the quality of the egg decreases, but at the same time, it causes a hormonal imbalance. There's no ovulation. The menstrual cycle is irregular. The lining can be out of sync and not receptive for implantation. And therefore, all of these factors can contribute. If it didn't contribute, then you wouldn't be seeing a fertility specialist in any case. But if you are going to the next step and you want to conceive, then it is important that we optimize whatever we can. It's not easy to lose weight. We all know that. We all have tried it, and it's an ongoing sort of a thing. And it's not important to keep that thing in your mind to sort of think that without losing weight, nothing's going to happen. But to make an effort, and to make an effort without taking the stress in this situation, I think that's what's required. Knowing that little things, just losing a 10% of body weight will have a positive impact on fertility, on ovulation, make the lining better, and receptiveness to hormones if we are giving them from outside. Having a healthy diet. And I always say that there's no point of us doing strenuous exercises which will make us burnt out. But if every day we made an effort to just walk or do something which would be like weights, is simple enough to do, and you can do that at home sitting down. I know it takes much more than what I'm trying to say, but little things, little changes, and they would make an impact. And obviously the ideal would be to be in the ideal sort of weight, because a healthy weight is also going to minimize the complications in pregnancy, which include high blood pressure, diabetes in pregnancy, preterm labor, small babies, and other things. We don't want to scare the whole thing, but ideally, when you're entering into pregnancy, an ideal weight would also be something that is desirable. So it follows that we should start very early. Next slide, please. Alcohol. When we're talking about alcohol, and I think we all sort of need to address this, yes, we know that having alcohol can decrease the sort of sperm quality. It can cause effects in ejaculation. It can cause, but we're talking about alcohol addiction here. We're not talking about sometimes socially having a glass of wine or something. And of course, it's important, but I feel that when a couple is trying in a journey, or even an individual person is trying on a journey to achieve pregnancy, and sometimes it takes time, and then compromising on everything, sort of blaming a glass of wine occasionally, I don't think that's such a big deal. It's when we're talking about alcohol, we're talking about high doses of alcohol. And of course, in pregnancy, no alcohol is acceptable. It has to be zero alcohol, because any amount can impact the baby. So again, getting into that mode of no alcohol would be ideal. It also is good for the egg quality not to have any alcohol. So it's very important that changing those habits earlier if we can. Next slide, please. Now, this is something, again, smoking, and I think everyone is already aware of the effects of smoking. There is nothing that actually benefits from smoking. The only sort of research which says that there might be a little bit of less endometriosis, in severe endometriosis with smoking, and that has also not been proven in studies. actually smoking affects everything, every part of the body, starting from the brain right down to your bladder, and there is nothing that is impacted positively. Fertility is affected more so because of the stress that is created by the oxygen-free radicals, by the smoke, by the chemicals in the body which are in the smoke. And smoking, vaping, shisha, none of them are acceptable, none of them. It affects the morphology of the sperm, it affects the motility of the sperm, it affects the quality of the sperm, it increases DNA fragmentation and damage to the sperm, and this can cause in itself, the impact can be so severe that it can cause chromosomal abnormalities, it impacts implantation, it impacts the response to IVF. So smoking is definitely a no, and as early as possible. Next, please. Recreational drugs. Broadly, I would say that the most important, it's not very common to find people on drugs, but none of the drugs are safe for egg quality, for sperm quality, and they also negatively affect the mental psyche, the emotional psyche of a person, and affect the overall possibility of getting pregnant. For men, and this is one of the things that I have started checking, especially with an affected sperm, using any sort of drugs which will enhance your muscles and which will make you more, performance enhancing, they're going to impact the sperm. Any testosterone from outside is going to turn off the factory within the body, and the sperm is going to sometimes be permanently damaged. So no steroids, no testosterone. And also if there's diabetes, we have to sort of consider that there might be a retrograde ejaculation happening because of the nerve damage. It is strongly recommended to stop all drugs in any form, and to actually start taking multivitamins and antioxidants. Next slide, please. I have briefly mentioned this before as well, and I think the most important thing to sort of take away from my talk would be that if there is any indicators when since menarche or later in the adolescent age, that the periods are heavier, periods are painful, there is irregular periods, there's acne, there is issues with hair growth, these are all silent flags to think that maybe there is something else going. Does every girl need to be taken to a specialist so early, like, if you are flagged off? No, the GPs are able to maintain and monitor all of this. And literally the most common treatment for managing anything in the younger age group, which is also protective for the ovaries, is contraceptive pill. And it will regularize the periods, it will decrease the bleeding, it will decrease the pain, it will also save the ovaries from damage, and therefore it will protect your ovarian reserve. So the GP can simply manage it at that time, but then being aware that these were the things that the pill was started for, and if you stop the pill and do not get pregnant, then that is the time that you would seek a specialist's advice. Next slide. Similarly, there are conditions which would impact sperm, and there is a few genetic conditions which we have to sort of think about, like cystic fibrosis. We know that it blocks the little pipes which would get the sperm out into the ejaculate. So we have to check for that if there is no sperm or if there is compromised sperm in a sperm evaluation. Similarly, the childhood trauma or childhood infection, like which caused orchitis and undescended testes, a thorough history will tell us, will identify most of these things. And if there is by any chance less hormones, because you would evaluate a person who comes to you with an affected sperm with hormones as well, and if the hormones also show that there is testicular failure, then doing a karyotype to see what the chromosomes are like would also be recommended. All of these can be definitely sort of identified, and again, there is treatment for most of the things that we have. Next slide, please. What are the steps that we can take generally without sort of thinking about the more medical conditions? Folic acid, we take it every day. At least 3 months of folic acid in your body prior to conception is recommended because it reduces the chances of having malformations in the baby by nearly 80%. And these are the brain and the spinal cord malformations. Having a well-balanced diet with an abundance of fresh fruit and vegetables, again, the antioxidants, would make the body be as healthy as possible. Moderate amount of exercise. It's not actually exercise, but make it a part of your life that at least 3 times a week you do something for yourself. It's just self-care. Quit smoking and minimize your alcohol. These are the minimal sort of things that someone should start with when you're attempting to conceive. Next slide. To improve the sperm quality, again, it's similar things. Quit the smoking, minimize your alcohol, no anabolic steroid, nothing to sort of work out the body. If you're taking drugs to do that, stop all recreational drugs and eat a balanced diet with an abundance of fruit and vegetables. Next slide, please. I think that's it for me. I'll sort of ask the next presenter to take over with the next next part of the seminar. I'll be around to answer any questions later. Thank you.
Hi, everyone. I'm Dr. Namrata Bashra, and I'm going to be talking about investigations and early intervention options. So my laptop just decided that wasn't going to work. So I'm just on my phone, so it's going to just look a bit odd. So please, please just bear with me. Okay. So when should you see your gynecologist, or when should you just go to your GP asking to see a specialist? Well, if you are under 35 years of age and you've been trying for 12 months or longer, then you should just see your GP because something is not right or needs to be investigated anyway. So most couples, 85% of the couples will fall pregnant within the first 12 months of trying. And then sometimes if you just wait a little bit longer, you will fall pregnant spontaneously. But when you get to that 12-month mark, if you haven't fallen pregnant, go and see your doctor so that they can organize tests to make sure everything's on the right track. If you're over 35 years of age and you've been trying for 6 months, it doesn't hurt to go and see your gynecologist that little bit early, just to make sure all is good and that you just don't need a little help to just optimize fertility. You should see your doctor earlier if your periods are irregular, or if you're not getting periods at all. Well, that's a concern. Or if you have a known history of polycystic ovarian syndrome or endometriosis. If you ever had any sort of infections in the past, or STIs, or sometimes, cancer treatment, then once again, it's a really good idea to just go and touch base with a specialist that early on, just so that they can just have a thorough look at everything and help optimize your health to give you the best chance of falling pregnant in a timely fashion. Next slide. So let's go through the initial investigations that will be organized when you go and see your specialist. So your gynecologist will take a thorough medical history. They'll take a thorough menstrual history. They'll just have a chat with you regarding how are your periods going. Just look at if your periods are heavy or painful. Are your periods too frequent or too spaced out? All of that. They will also, go through your medical conditions, your medical history. Is there anything in that medical history that could be affecting you? chances of falling pregnant, as well as a family history. Your doctor will usually organize a pelvic ultrasound scan for you in that sort of first half of the cycle. And that pelvic ultrasound scan is to look at how many follicles do you have in each ovary. So a normal count, and we call this the antral follicle count, a normal antral follicle count would be about 8 to 10 follicles. So they would just want to have a look to make sure that at least 8 to 10 follicles in both ovaries to make sure that the fertility is sort of within that normal range. The pelvic ultrasound scan is also going to look at your uterus. It's going to look at if there are any fibroids, if there's any endometriosis in the muscle wall of the uterus, so that adenomyosis, or if there are any polyps, or also looking at what those fallopian tubes are looking like. You know, are those normal, just making sure they're not too dilated, or any other concerns with any of that. They will organize some baseline blood tests for you. So things like the baseline hormone levels, so your follicle stimulating hormone level or your FSH, and your luteinizing hormone level or your LH. And they'll also look at your baseline estradiol. Another very important hormone is thyroid hormone or your thyroid function. So they'll check your thyroid stimulating hormone. It's very important to optimize your thyroid function to help with fertility and also to decrease risk of miscarriage. If your TSH is normal, then they would also want to check your prolactin levels. Your doctor is going to screen for any STIs at this visit, as well as look at your anti-Mullerian hormone level. They'll also organize infectious disease screen, including rubella and chickenpox. If anyone is not immune to rubella and chickenpox, and if they contracted the infection in pregnancy, then it can cause congenital birth defects. So it's really good to have that blood test before you fall pregnant, because if you're not immune, then your doctor can organize a vaccine for you to provide you immunity and then protect you and protect the baby. Genetic carrier screening tests are organized to look at some recessive genetic conditions. The 3 of the most serious reproductive genetic carrier screening tests that are organized are cystic fibrosis, spinal muscular atrophy, and Fragile X syndrome. These tests are not Medicare rebatable, so that's really good news, and everyone should have these tests before they start planning a pregnancy. Next slide. Your doctor will also organize that hysterosalpingogram test or that hyphosi test, and that one is to check the patency of the fallopian tubes, make sure those fallopian tubes are working well. And again, you know, with the, at the time of this test, once again, it's a good opportunity to look for any fibroids, any polyps, adenomyosis, any ovarian cysts. Some tertiary gynecological places can also look for deep infiltrative endometriosis at the time of this test. In addition to these tests, the other tests that are organized are semen analysis for the male partner. And if your doctor is concerned regarding endometriosis from your history or your examination, then on top of that tertiary gynecological ultrasound scan, you know, they might recommend laparoscopy if pain was a big problem, or if there was frequent bleeding or some other sort of abnormal bleeding that they were worried about. Next slide. So let's talk about the anti-Mullerian hormone levels. Now, anti-Mullerian hormone level is not a test of fertility per se. It's more of an indicator of your ovarian reserve. The most important thing to remember is that age is the biggest predictor of fertility. So the sooner you can possibly start trying for a pregnancy, the better it is. The anti-Mullerian hormone level gives you an indication regarding what your ovarian reserve is. It helps a specialist decide regarding the dosing of the hormone medication for IVF. And it also sort of predicts what your response is going to be to your IVF medication. Next slide, please. Now, this graph shows the value of AMH in comparison with respect to the age, and what does it tell about someone's ovarian reserve. So, if someone is about 30 years old and if the ovarian reserve is 2, well, that's poor ovarian reserve. If someone is 40 years of age and if the AMH is 15, well, that's really good ovarian reserve for them. So the AMH, it varies with age, and depending upon the age, it tells us what someone's ovarian reserve is. Once again, I would like to reiterate, it's the age that's the biggest predictor of fertility. So in women who are 25 years of age, or again, at someone who was about 31 years of age, and the AMH was 2, and they still fell pregnant without a problem. Next slide. So with semen analysis, what we look for is the ejaculate volume, sperm concentration, total sperm count, sperm motility, sperm morphology, and sperm antibody tests. So there's WHO guidelines regarding the normal range, and we just make sure that the sperm, all the variables fit into that normal range, and if not, then we recommend treatment accordingly. Next slide. A normal sperm has an oval head and a long tail. Abnormal sperms, they can have heads or tailed defects like large or misshapen head or crooked or double tail. These defects might affect the ability of the sperm to reach and penetrate an egg. Next slide. Once your doctor has gone through your thorough medical history, examination, and organized all these investigations, they're going to develop a fertility treatment plan that fits with your health and treatment. Where possible, we always try less invasive early intervention options before moving to IVF treatments. Next slide. So let's go through what are the various early intervention options available for people with various conditions. So if there were some large fibroids, especially the ones that are affecting the quality of the fibroids that are affecting the cavity, the uterine cavity, like if they're distorting the uterine cavity or something, or if there are ovarian cysts or endometriosis, or if there's any tubal conditions, then the doctor would recommend treating these conditions and sometimes just removing the fibroids and removing an ovarian cyst or endometriosis will then help those women conceive naturally or with intrauterine insemination after that surgery. If the fallopian tubes are blocked, then patients won't be able to conceive naturally or with intrauterine insemination, and then IVF will be needed in those clinical situations. Next slide. So again, we've been through this in the previous talk as well regarding early interventions for poor sperm quality. I'll quickly give you a rundown of these again. So there are certain conditions like, sort of blocked vas deferens or some varicocele or other anatomical abnormalities that can affect sperm quality. So surgery to treat these conditions will then help with sperm quality. The other option would be testicular biopsy and IVF treatment. Certain medications can affect sperm quality, so using these medications will help. Again, if someone's taking recreational drugs, then again, stopping those recreational drugs will make a huge difference to the quality of the sperm as well. If there are any hormonal issues, then hormonal treatment will be recommended. And once again, as we've heard earlier, lifestyle changes can help with sperm quality. So quitting smoking, limiting alcohol intake, healthy diet, regular moderate exercise, and minimizing toxic chemical exposure helps with sperm health as well. If there are any STIs or any infections, treating those is going to help with sperm quality as well. Next slide. When your doctor's taken a thorough history, if they feel that you're not ovulating and that's what the primary causes of infertility, then they will recommend ovulation induction. So ovulation induction is going to be a good option if you're not having regular periods or if you have a known history of polycystic ovarian syndrome. In women who don't have any periods at all, ovulation induction is going to help in that situation as well. For ovulation induction to be beneficial and successful, it is important to have patent healthy fallopian tubes. Sometimes ovulation induction can also be an option in unexplained infertility. Next slide. Ovulation induction is usually achieved by administering medication. So the medication allows a follicle to grow to a stage that it contains a mature egg. All follicles at the beginning of the cycle are about 10 millimeters in size. The ovulation induction medication usually helps one follicle to grow to that sort of 2 centimeters size, and that's when it ovulates. Your cycle is closely monitored with blood tests and ultrasound scans to pinpoint the time, almost the exact time when you'd be ovulating. And then you can either have timed intercourse or intrauterine insemination for when that ovulation is occurring to improve your chances of falling pregnant. Sometimes a trigger injection is given, once again, to just pinpoint that timing of ovulation and to help with the hormone levels as well. Next slide. So there are 2 oral ovulation induction medications that are used widely. One is clomiphene. Clomiphene has been used for ovulation induction for decades. And one of the new ones is letrozole that's been around in the last 10 years or so. Both these medications are completely safe. Both of these medications work by blocking estrogen receptors. And what that does is that it makes your pituitary gland think that there isn't enough estrogen. And pituitary gland is what releases that follicle-stimulating hormone. And it just releases more follicle-stimulating hormone, which then goes and works on that one follicle to make it grow from that 10 millimeters to that 2 centimeters, hopefully in those 14 to 16 days, to then induce ovulation. Next slide. If either the clomiphene or letrozole is not the right medication for ovulation induction for you because of the medical condition that we're treating, or you've tried ovulation induction with clomiphene or letrozole, it hasn't worked, then the next option is ovulation induction with the follicle-stimulating hormone injections. So as we discussed earlier, medications like letrozole and clomiphene make your pituitary produce higher dose of follicle-stimulating hormone. But with the injections, we are actually giving you the follicle stimulating hormone in the injection. So then that works on your follicles to make them grow bigger to that size for them to then ovulate. Next slide. There is risk of multiple pregnancy with ovulation induction. So with letrozole or clomiphene, the risk of multiple pregnancy is about 5%. With the follicle stimulating hormone injection, the risk of multiple pregnancy is about 10%. And there's also that risk of ovarian hyperstimulation, and both these conditions can occur if there's more than one egg is released when you ovulate. With the increased risk of multiple pregnancy, that increases the risks to the mother and the baby, because multiple pregnancy, like twins or triplets, increases risk of preterm births. That's got implications on the baby's neurological development and all of that, and also increases risk of diabetes, increases risk of high blood pressure, and obviously operative delivery. Next slide. Another option, if you're already ovulating, is ovulation tracking. So if you just go and see a gynecologist, your periods are pretty regular, but you're not falling pregnant, then initially you can just trial ovulation tracking to see if that'll help improve your chances of falling pregnant. Again, what this involves is ultrasound scan around that day 10 to day 12 of the cycle to see if you're ready to ovulate, just tracking those follicles. And if you are, then your doctor might recommend that ovulation trigger injection, and then timed intercourse or intrauterine insemination, depending upon whatever your preference is. So sometimes the doctor might want to do blood tests with this. Other times they'll just do an ultrasound scan mid-cycle. And the ultrasound scan is usually a transvaginal ultrasound scan. Then they'll usually organize a blood test in that luteal phase, so about 7 days from when you've ovulated, to confirm that yes, ovulation is occurring, and just make sure that your progesterone levels rise satisfactorily in your cycle. Next slide. So timed intercourse, as we just discussed in the previous slide, it just goes hand in hand with that sort of ovulation tracking. So your doctor's going to just perform that sort of transvaginal ultrasound scan, usually around that day 10 of the cycle, to see when you're going to ovulate. Sometimes recommend an ovulation trigger, and then yes, timed intercourse around that time is going to improve your chances of falling pregnant. And sometimes if everything else is going all well, you're not falling pregnant, they might even give you a low dose of like letrozole or clomiphene to improve your chances of falling pregnant, in addition to that ovulation tracking and timed intercourse. Next slide. Intrauterine insemination. So this is also known as donor sperm insemination or artificial insemination. The good thing about this treatment is that this requires minimal intervention. And it's sort of almost a sort of supportive treatment in a lot of ways in just taking you through a cycle. You do not need a lot of medication with IUI either, so that works out really well as well, and that's why it's a very highly acceptable treatment for a lot of couples. So for the IUI treatment, the important things are that your fallopian tubes should be patent, because that's the only way this treatment will work, because once the sperm is inseminated into the uterus, that it has to go through the fallopian tubes, and the egg has to be picked up by the fallopian tubes as well for the fertilization to occur in the fallopian tubes. So it's very important to have patent fallopian tubes for IUI to work and for IUI to be an option for you. It'll be good if there's a good ovarian reserve as well for this to work. And yes, we'll have to make sure that you're ovulating. So once again, this is going to involve that tracking of ovulation and potentially that ovulation induction medication to help improve your hormone levels as well. As I discussed earlier, age is the biggest predictor of fertility. So if you're 29, this is a great option for you. If you're 39, then your doctor's going to have a thorough chat with you and just counsel you thoroughly in what do they think the success rate of this condition is going to be, of this treatment is going to be for you. Next slide. So let's go through the process of IVF, the process of IUI. So as I mentioned earlier, this is a very simple sort of process, and it does not need a lot of intervention, and that's why it's very highly acceptable by most women and most couples. What this involves is you might be prescribed a medication, one of those ovulation induction medications, if it's appropriate. Then your doctor is going to do that ovulation tracking by performing that sort of ultrasound scan around that day 10 to day 12 of your cycle. And they're going to look at the follicles. They're going to make sure that there's a good sized follicle there for you and to be ready for ovulation. They're going to advise you to take your ovulation trigger. And then they're going to organize for the IUI to be performed the next day. With the process of IUI, your partner is going to provide them the semen sample. A very experienced embryologist will usually and they will prepare that semen prep, which is a bit of a concentration of sperm in about 1 ml of the in 1 ml volume of the semen, and then a clinician, which could be either your fertility specialist or your fertility nurse, they will then perform this IUI by putting a catheter through the cervix and then administering the sperm into the uterine cavity. And then, yep, you can just get on with your day. You don't have to take any time off. There's just no specific precautions. And then usually we'll do a blood test about a week later to make sure that yes, you did ovulate, and that yes, your progesterone levels are rising appropriately in that luteal phase. And then the next blood test, which will be the pregnancy test, that's in about 2 weeks from the test. Next slide. So then the question is, what treatment is right for you? So that will depend upon all the factors that we've discussed in detail during this presentation, which is your menstrual cycle, are you ovulating, your age, your AMH, are your fallopian tubes patent, what's happening with the sperm. Okay, so if the main problem is the male factor infertility, where the sperm concentration is either low or there's low number of sperm with normal morphology, then it's going to be recommended that you go through IVF with ICSI, which is that intracytoplasmic sperm injection, where the scientist will pick a sperm to then fertilize an egg. If the main problem is ovulation, that the ovulation is not occurring, then ovulation induction would be the way to go. If there is a tubal condition, like either the fallopian tube is blocked or if it's dilated, then most times IVF is the recommendation. Some women might want to trial things like microsurgery of the fallopian tube, But those treatments are not readily available. And the reason for that is that those treatments might not be successful. And even if the treatment is successful, because that fallopian tube is potentially damaged, there is that high risk of ectopic pregnancy. So most times with tubal disorders, IVF ends up being the treatment of choice. If there's unexplained infertility, then the options are going to be either IUI or IVF. Then if there is, if the cause of, if you're seeking fertility treatment because you're single or same-sex couple or LGBTIQE community, then yes, either IUI or IVF is going to be a good option. Next slide. So when do we recommend IVF treatment? So once again, as we discussed, if there's severe male factor infertility and if there's an issue with the sperm, then yes, the recommendation would be that IVF with ICSI. If the partner is at vasectomy, and then yes, there is that option of the reversal of vasectomy. At times it doesn't work, or if the preference is not to put oneself through that procedure because it might work, might not work, then yes, IVF is a great option. If the fallopian tubes are blocked or damaged, then IVF is the recommended option. If you've been through about 2 to 3 cycles of IUI and it hasn't worked, then the recommendation would be to proceed with IVF. Once again, sometimes it depends upon age as well. One of the other indications for IVF would be recurrent miscarriage. That is because most recurrent miscarriages occur because of chromosomal abnormality in the embryo. So then the recommendation is to go through IVF and then get the embryos tested for any chromosomal abnormality. Then the recommendation is to implant an embryo with normal chromosomes to help improve one's chances of falling pregnant and to decrease risk of miscarriage or that first trimester pregnancy loss. If surrogacy or donor eggs are required, then IVF is the treatment option of choice. And the other scenario where you will need IVF is if the sperm's been frozen before, let's say, cancer treatment, and then depending upon the volume and quantity of sperm collected and before treatment, IVF with ICSI might be recommended. Next slide. Well, that's all from me, and I'll be around to answer any questions at the end of the presentations today. Thank you.
Hello, everybody. Good evening. Thank you for attending this late evening webinar. It's really nice to see you attending such huge numbers. I'm Nikhil Patravali. I work in Sydney as a fertility specialist, but I've also got keen interest with fibroids, endometriosis, PCOS, and a myriad of gynecological conditions that I treat through my rooms at Monash. Before I kick this off, I'll also say, please stay back for the Q&A session, and we as panelists will try and answer a lot of those questions as much as possible. But really some interesting questions coming our way. I've already had a sneak peek through that. So let's just kick this off. So what is IVF really? Yeah, IVF stands for in vitro fertilization. What that means in Latin is really within the glass, as the egg and sperm are meeting really outside the body, and it's not the most conventional way that they meet. The first baby of IVF was born more than 4 decades ago, and the rate of IVF is increasing. What that really means is IVF is a relatively new specialty in the grand scheme of things in the medical world, but it's a very big translational science. And everything that is possible and successful is getting implemented in, and we are seeing success year on year improving because of that. But in real terms, it also means 1 in 25 children born in Australia are conceived via IVF. So although at a very personal level, couples would feel that as an isolating experience, you will find a lot of people around you who've had this treatment, and it's a very commonplace and actually a very safe medical procedure. So when is IVF needed? Really, a full fertility assessment may identify perhaps some reversible causes. And as my previous speakers have mentioned, you may need some less invasive and perhaps some early intervention options that may be appropriate for you. But for some couples, that may not be possible, and you may need IVF. But there are certain unique situations as well, like if couples are needing donated eggs or sperm, you may require that may be required to achieve a pregnancy. And for some people, which surrogacy may be the only pathway, IVF forms perhaps a very important cornerstone in their treatment. So what happens really before IVF? When you come and engage with Monash and you see a doctor or a specialist, you would perhaps, of course, you discuss your plans as a family. It's very important for us as medical professionals to understand where you're coming from, to understand you as a family, first of all. But we'd also do the whole scientific way of moving forward. We take your history and we review the text to explore your fertility, and if you and really make you ready with all the blood tests and all the other advice that has already been mentioned to prepare you for this journey. And a lot of these tests would include semen analysis, ultrasound, for example, as well. We then determine the best treatment pathway with what is going to achieve that end goal for you. But really, it's very important that you feel very comfortable through this process. I always say to my patients, we're all in this together. And that's really a very important aspect. This is the only science where the journey can feel a little bit prolonged and a bit more daunting as well. But you always have counseling to your side. Monash provides a great counseling advice, not only to couples who are going through this emotional journey, but also some very specific counseling in case you're needing donor gametes, in particularly with implications counseling. You will also engage with our nursing team, and you'd have nursing interviews to make plans for the day as per the logistics of this fertility treatment, which has been deemed necessary for your care. We move on. The next slide. We will see that perhaps it's a very simple, pragmatic way of looking at the process. This is just one representation of how an IVF could work, but normally most IVF cycles would commence from day 1 of your period, and the principle is to stimulate the ovaries. Follicles are fluid spaces in the ovaries, and with the hope that there is one egg into each of these follicles that are retrieved. We stimulate the ovaries when it's the right time with the hormones and size of the follicles. We perform a collection. We then prepare the sperm on the same day, and the sperm is mixed with the egg. Embryos are made, and embryo transfer is conducted. After a few weeks, we do a pregnancy test. If that's positive, invite you for a scan, and perhaps that's the end of that particular journey. If not, we may have to repeat the whole process again. This is the basic pragmatic representation. But the next slide shows you a bit of a timeline, which is slightly a better representation, where if you think about it, an IVF cycle is like your one menstrual month. It takes around 28 to 30 days to complete, start and complete. So you call with your periods. From the 2nd or 3rd day, you start your stimulating hormone injections, which is also the follicular stimulating hormone. You may introduce another injection depending on your cycle, called as an antagonist. And we regularly monitor your ovaries. And once they reach a particular size, we ask you to stop both of those injections and give you a final maturing injection called as a trigger injection, which then follows on with egg retrieval. We then culture the embryos after fertilization and allow for some endometrial support. So women would take some medications through their vagina for that to occur. And around day 5, we'd encourage an embryo transfer. Beyond that point, you continue with your endometrial support, and we'll invite you around day 9, day 10 for a pregnancy test. And if that's positive, after 2 weeks for an ultrasound scan. So how do we really stimulate your ovaries, right? So in a natural cycle, if you can imagine, sorry, next slide, please. You can imagine there is one large follicle that is produced in a particular cycle. However, so follicles or fluid on a scan looks black. So everything black is fluid filled on screen on the right. But in an IVF cycle, using hormonal injections, we then want more than one follicle to come through the cycle. So we are able to collect more than one egg as you come through the cycle. And that is the principle of IVF and giving you a lot of that medication. But remember that medication is actually the same medication that perhaps is produced in your body in small quantities to produce just one follicle. Next slide, please. So the medication is generally injected in the tummy, but there are other routes of taking some other medications to support the stimulating injection is either vaginally or using nasal sprays. Or you could have a combination of all of these and they form part of your stimulation plan. It usually starts around day 2. So we encourage women to call with the first day of their period. And then we would perhaps do a blood test to check that the ovaries are baseline and then start their stimulation. It takes around 8 to 14 days at the first instance of taking these injections till the ovaries respond and reach a particular size and recruit adequate number of follicles that reach to maturity for collecting the eggs. This is then combined with a medication to block the natural ovulation as well, and that is called as an antagonist. And hence, it's a very controlled way of looking into procuring the eggs. So you don't lose the eggs in yourself, but we get to collect them. The ovaries and throughout the IVF cycle, there is intensive monitoring through a combination of blood tests and ultrasound scans. And most of these scans are internal scans as the ovaries sit right on top of the vagina and behind the pubic bone. And that's the most adequate way of measuring the follicles as well. Of course, if there are certain conditions that prevent women from getting a transvaginal ultrasound, we could then do a transabdominal as well. This also allows us, through serial monitoring, to adjust the medication if required, and also prevent a condition called ovarian hyperstimulation syndrome. What we aim for is to actually collect between 8 to 12 eggs or 8 to 12 follicles coming through the system. But if you're producing almost around 20 follicles or 20 eggs that come through the system, it can lead to a syndrome called ovarian hyperstimulation, where women can lose a lot of fluid in their belly, around their heart, around their lungs, and also that increases the risk of clots in the legs and in the lungs as well. And we then adjust the treatment plan to see how you responded to increase your chances of the pregnancy as this comes through. Once you reach a particular size and level of hormone, we then say that you're ready for the trigger injection, which allows for final maturation of the eggs inside of these follicles. So it normally takes around 8 days for these to grow, and maybe slightly longer. But once they reach the right size, as I mentioned, we use the trigger injection. The trigger injection is a very different injection to the stimulating hormones. And what it does really is it changes the oocytes to what's called M2 oocytes, and they freely float. They fall off their perch from the follicle and they freely float inside the follicles to be able to collect them. The different trigger medications that are used depending on the risk of ovarian hyperstimulation, and that plan can change depending on your response. If you're at risk of ovarian hyperstimulation syndrome, we may not encourage you to undergo an embryo transfer straight up, and you may need a period before then commencing a frozen embryo transfer cycle, where from the fresh cycle, we would have frozen the embryos and stored them in liquid nitrogen. Your fertility nurse will tell you exactly when to give the trigger injection, and perhaps the timing of this injection is the most crucial. It is exactly 36 hours prior to egg collection. Of course, we've got a leeway of a few hours beyond that. But if you at all need to remember anything with medications, the timing of the trigger injection. So once you get the trigger injection, you then come in for egg collection. As I mentioned, it's 1.5 days after the trigger injection. You're put to sleep, your legs go up in stirrup, and we do a transvaginal ultrasound scan exactly for what you've had for counting the number of follicles. But this time, there is a needle guide that sits on top of the scan probe. It goes from the top of the vagina into each of the ovaries, into the fluid spaces that you've seen. And we suck the fluid into test tube and pass that to the scientist in theater. The scientists sit with like a mini laboratory in there, who then run the fluid under microscope. And even before you're wheeled out of theater, we know how many eggs have been collected. Next slide, please. So the eggs are then transported up to the lab, where either you could undergo a traditional IVF treatment or ICSI treatment, which is intracytoplasmic sperm injection. Now, in IVF, around 20 to 30,000 sperm are mixed with the egg, and it allows for natural selection of the sperm, where only the best sperm gets in, and fertilization is possible. Sometimes, if there is poor quality of sperm, or with previously failed IVF treatments, or with poor fertilization demonstrated with IVF, we would then recommend for ICSI treatment, where our experienced embryologists then select one sperm and inject into the egg. And that's shown in the other picture up on the slide. Once these eggs are fertilized, they're kept in laboratory in very strict conditions, and they are grown up to day 5. On day 1, you get fertilization, where you can see in the first picture on the left, you get 2 pronuclei, or nuclei, one from the mom, one from the dad, and that is a good sign of fertilization. From day 2 onwards, the embryo then starts to split into number of cells. So day 2 is 4 cells, day 3 is 8 cells. The analogy that I give to couples with this is like a transformation of a caterpillar to butterfly. So till day 3, the cells are just dividing. On day 4, they go into like a cocoon stage. It's a bit of gobbledygook. You can't make out whether there are any cells or if there's any transformation, and that's called morula stage. But the biggest transformation occurs on day 5, which is called as blastocyst, where the cells then differentiate into what is called as the inner cell mass, which is around 1 o'clock position, a clump of cells that actually makes the baby, and their surrounding cells called as trophectoderm. The highest success of fertility now, which is proven through research, is on day 5. And hence we would highly encourage couples to get a day 5 embryo transfer to avail of best success rate as well. So how do we really conduct a embryo transfer? The embryo transfer is almost like the intrauterine insemination that was mentioned by my previous speaker. So you're awake for this procedure. You come with a full bladder. And this is the only time where you'd get a ultrasound on your abdomen. A very fine cannula is inserted through the uterus. In fact, we try not to manipulate the uterus too much or stimulate it, so it's in a better condition to receive the embryo. And we then deposit the embryo through plunging it through the system. The scientists load a few air bubbles around the embryo, and they look like bright white spots, which are seen on the top corner of that screen. And that's when we know that the embryo is placed. Monash regularly uses what's called an embryo glue, where the embryo bleeds for minimum of 30 minutes at least to help latch onto the embryo. And that has shown improvement of success by even 2 to 5% as compared to cases where we don't use embryo glue. So it's a very standard practice in Monash to enhance the success of fertility. Next slide, please. So when is a fresh transfer used? Now, majority of the cases you would encourage a fresh transfer, in particularly when there's no genetic testing required for embryos. Genetic testing takes around 2 to 3 weeks for the results to come back. So really, a fresh embryo going into someone cannot be tested. It also reduces the risk of embryos not surviving the freezing and thawing process that can occur with the frozen embryo transfer. And of course, it allows for the shortest time through pregnancy as well. But as you compare it with a frozen embryo transfer, if there's genetic testing required, then you would wish for frozen embryo transfer. Patients with increased maternal age, perhaps more than 35 or most definitely around 40, could choose for a frozen embryo transfer by testing the embryos first of all. And the patients with polycystic ovarian syndrome, where if there has been a lot of ovarian hyperstimulation, then we would encourage a frozen embryo transfer. So freeze, as I mentioned earlier, we freeze the embryos and then invite you for a very different kind of preparation of the uterus to receive the embryo. If you look in a bit more detail with pre-genetic testing of the embryo, the different kinds of pre-genetic testing. Now that's the PGT can only be done in embryos that are hatching. So you can see the pipette that is taking the cells out is actually not digging into the embryo. And you only take the surrounding cells, not the inner cell mass that actually makes the baby. And you send that away for testing. An embryo is really tiny, and these are even tinier cells that are taken for testing. And results can come back in 5 categories. They can come as no abnormality detected, which is an ideal situation, aneuploidy, where there can be problems with chromosomal numbers, or mosaics, where some of the cells are normal, some are abnormal. There can be failed amplification of these cells as well that can occur. You could still use those embryos where the result is they couldn't amplify the cells to test, or the 5th category is inconclusive. So despite testing, they can't really conclude whether it's normal or an abnormal embryo. Now remember, at Monash, we would only test embryos that are looking a good grading of embryos. If the cells are falling apart, if the embryo is falling apart, there's really no point doing any PGT testing on those embryos. There are different kinds of PGT. So, you can have what is called PGT-A, which is PGT aneuploidy, where we look for if there are 2 copies of chromosomes on all the chromosomes, which is how human beings are designed. If there is an addition of the copy, which occurs in conditions like Down syndrome on the 21st chromosome, so if there are 3 copies instead of 2, or if there's a deletion of chromosomes, then you can identify through PGT-A. These embryos, although they look good, may not do well with implantation and can lead to miscarriages as well. There's certain very specific monogenic conditions as well called PGT-M that can be looked at, in particularly like spinal muscular atrophy. So this is a different kind of PGT-M that Monash has as on offer as well. So all in all, what do we understand with success, chance of success with IVF? Now, this is really very specific to the individual, their background, their histories, their individual conditions. And even if there are conditions like endometriosis, for example, it can vary in intensity and what effect it is having on the person that can dictate your success. This is a very good website called Your IVF Success, and you can look at any clinic, not just with Monash, to see what they offer and the success rates and so on. And I highly encourage everybody to go on to that. But one of the things to consider definitely is maternal age is considered very important in our world. So it's really important that we consider this. And I think as couples, you should perhaps come in a little bit earlier than later, because that does dictate fertility. Science has not evolved at that stage where we have still decoded why that occurs with reduction in success when women get older. The cause of infertility or reason why you need IVF plays a very big factor in the chance of success as well. Of course, if there's multitude of factors or multifactorial, the chance definitely goes down. Lifestyle plays a very important role with weight as well, or with things like smoking or recreational drugs, alcohol as well. So I think a lot of things need to be considered. But what I say to my patients is, come with a lot of faith. It's a very courageous step coming through for IVF. It feels a bit isolating, but I believe all the Monash centers are really good. They're very welcoming. We understand the white elephant in the room, that is perhaps the stress that couples come through. And we want to work alongside our patients to make it happen for yourselves. We are all in this together. So I just wanted to wish good luck to everybody before I finish. And I'll go back to the presenter for any Q&As.
All All right, it's time for some Q&As. We've had lots of questions come through. Unfortunately, we won't be able to get through all of them, but we will do our best. Dr. Varoshna, if you're able to answer this first one for us, what could be some causes as to why we're struggling to get pregnant a second time around?
It could be a few reasons, depends on what happened in the first pregnancy. I'm going to sound very repetitive, but it could be the age. What was the age at the first pregnancy? And we know that as we age, the next pregnancy can be harder. It could also be possibly the infection or anything that happened at the time of delivery, including a second stage cesarean, which could have affected the tubes. One of the things we have to also acknowledge is that most of the medical conditions like polycystic ovarian syndrome, endometriosis, adenomyosis, they worsen with time. And so it could be that it was easier to get pregnant the first time around, but then once the first one arrived, it took some time to sort of grow that child, get into the mode of trying again, and by the time things became more difficult.
Thank you, Dr. Varoshna. Dr. Namrata, are you able to answer this next one for us? Are there any supplements that we need to take to ensure egg and sperm quality are improved or as optimal as they can be? And this one also just says, I have a low AMH and want to improve chances of having high quality eggs.
Sure. Can you hear me?
Yes.
That's great. So we recommend coenzyme Q10. That is an antioxidant and has been shown to help fertility by improving quality of eggs and quality of sperm. So we highly recommend that all couples take coenzyme Q10 at least 300 milligrams once daily. And then melatonin. Melatonin is another antioxidant that can help with quality of egg, quality of sperm. So about that 4 milligram daily at least. For sperm quality, Menavit can be quite good as well. It's got a lot of macronutrients, micronutrients that can help with the sperm quality. So we do recommend taking one of those multivitamins as well. And then obviously the other things we've talked about, limit your alcohol and no smoking or recreational drugs. Yes. Low AMH, again, coenzyme Q10, melatonin are the important things. And a whole lot of stuff is sort of investigative things like the protein-rich plasma rejuvenation therapy. That's a bit of investigative, and we haven't seen great results from the few times we've tried it. I think another very important thing with low AMH, especially if you're young, look for endometriosis. If you're young, if you're 32 years old and got a low AMH, there could be endometriosis. So, just getting that treated is going to help improve your chances of falling pregnant.
Awesome. Thank you so much. Dr. Nikhil, I have a little question for you, if that's all right.
Sure.
Yeah, so this one goes, I'm 38 and I've had an ectopic pregnancy. What would you recommend as my path moving forward given my age?
I think first of all, I would say definitely engage with the fertility organization. As we've mentioned, age, first of all, plays a big important factor. So I think you need to look into your ovarian reserve. With ectopic pregnancy, there's a 15% chance of recurrence of ectopic as well. Cause for ectopic is also very important. Whatever has affected one tube could have affected the other as well. So I would also encourage and recommend to check for patency of the other tube, because if the other tube is blocked, the only perhaps way around this is doing IVF. And even for success of IVF, you need number of eggs, quality of eggs coming through. So I would perhaps say definitely engage with the fertility organization, first of all, mostly just for information gathering. So you're set up on the right path, and not necessarily IVF, but, if there are other complications that have caused the ectopic, then, that needs to be looked at. And that could be pelvic inflammation, that could be endometriosis, that could be a lot of other factors.
Awesome, thank you. Dr. Varoshna, if you're able to answer this next one for us again. It goes, during the monitoring process for IVF, does the patient need to visit the clinic for blood tests, etc., every day during the cycle, or how often?
So we have a protocol, usually depends on what sort of medication your specialist would have started you on. There will be baseline bloods And then once you start the medications, we usually do a blood test and an ultrasound on the 6th day of the cycle, which is 1 week, sort of approximately. And then based on that, based on what the bloods on that day are, you might have one more blood test. So it's quite doable in your day-to-day work. You don't have to visit every day. We can also organize for you to do it in your, before going to office, you know, go late an hour, and we're happy to sort of write that off for you. Do it in your lunchtime. We're happy to organize that. And sometimes do it locally, and we'll chase the results up. So we will try and make it as convenient as possible to you to minimize the amount of time that you have to take from work, or if you don't want to express it to the people around. And, you know, it would be as subtle as you like us to be. There's not many visits involved.
Great, thank you. Dr. Namrata, just another question your way. Do you have a maximum BMI for IVF, or is there a range that you recommend to be within?
So again, yes, I definitely, there's a range I recommend to be within. So, you know, it's ideal to be less than 30 or at least less than 35. And again, you know, if it's over 35, then it's just very important to, first of all, you know, just focus on health, just figure out what is causing that weight gain. Is it polycystic ovarian syndrome? You know, get that treated by targeted medication to help with insulin resistance, because we know that increased BMI decreases risk of, decreases success rate of fertility, and also increases risks to the mother and the baby when pregnant.
Thank you. Dr. Nikhil, just one last question for you. What are some options if there is infertility with endometriosis, and we are not too particularly keen on going for a laparoscopy?
Look, there's a lot of, it really depends on how bad the symptoms are and what you're looking for and what the background is. Have you been through fertility treatment or not? Endometriosis is a very poor witness. So you can have very little endometriosis, but it can cause havoc in a woman's life, symptomatically perhaps, or even with fertility. Or some women are studied with endometriosis and actually they don't even know about that. They get on with their daily business. So it's a very difficult question to answer. It needs to be looked into a lot of with a lot of perspective. But going back to non-surgical options, there are lots of medications that can be given to a woman. They of course take time, so they can take best part of 6 to 12 months to sort of work and act on, and really depends on the couple's take on the whole issue with, and of course everything else. So if you're a 40-year-old with endometriosis, I would perhaps say waiting for 6 to 12 months would probably not be an ideal situation. And if that is your cause for infertility, then you might need surgical intervention. Yeah, that would be my answer.
All right, thank you. Just one last question, which I can actually answer. So we have been asked, does Monash IVF have local egg and sperm donors? We do. We have 3 overseas donor egg clinics, which are Meta Medical, Central IVF, and the World Egg and Sperm Bank. And we also have a clinic recruited egg donor program. Each of our egg bank programs, they have different guarantees. So if you do have some more questions about that, it would be best to get in contact with our donor and surrogacy team. Our sperm banks are also similar. We have a few overseas ones, including CCV and the European Sperm Bank, and we also do have locally recruited donors. But again, it would be best if you have some more questions on that one, just to reach out to the clinics and get in contact with the donor and surrogacy team. Thank you.
Amara, can I just add something?
Yes, of course.
Okay. There are a few questions on the screen about genetics and genetic testing. I won't go into the specific because there are quite a few questions on it. Monash has a very good program with genetics point of view as well. So if you have a genetic condition, or if you're not sure, if you've already engaged with a geneticist, then we would say, come to us with all the letter information. And what we then tend to do is send all of that information to our laboratory which is centrally based, and a lot of our work in Sydney goes to Adelaide, and they do what is called as feasibility testing to check whether that condition can perhaps be transmitted to embryos or not. And once we get that information from them, we can then put people through IVF, test the embryos, and probably minimize the chance or risk of it being transmitted. I thought I'd just chip into that because there were quite a few questions.
Awesome. Thank you, Dr. Nikhil and Dr. Bajra and Dr. Cole for this evening. Really informative. Unfortunately, that is all we have time for tonight. Do apologize that we couldn't get through all of the questions, but if you do scan that QR code that we have, you can book a complimentary nurse chat with one of our fertility nurses, and they will have some personalized guidance on your fertility options. We would just like to thank everyone for attending tonight, and we do thank our doctors for their wonderful and insightful presentations, and we do wish everyone the best on their fertility journey. Thank you.
Thank you.
Thank you. Have a good night.
Good night, everyone.